Welcome to Key Insights from the 21st Annual Perspectives in Thoracic Oncology meeting here in the heart of New York City. My name is Corey Langer. I'm the Director of Thoracic Oncology at the Abramson Cancer Center at the University of Pennsylvania, where I am a professor of medicine. And I'm joined by one of my very important colleagues, Josh Baumel, who's an assistant professor in medicine and works side by side with me in the oncology division with a focus on thoracic oncology. So, Josh, welcome.
Thank you very much, Corey.
A lot's happened over the last couple of years, particularly the last year in thoracic oncology. What do you think are some of the major advances?
I think that the inclusion of immunotherapy has been a huge boon for patients with lung cancer. Most recently, of course, the data from Keynote-24, when for the first time ever, we've seen something beat out platinum doublet or platinum-based systemic therapy for lung cancer. So in that population, of course, patients who had greater than 50% staining of PD-L1 had an improved overall and progression-free survival with pembrolizumab as opposed to platinum doublet chemotherapy.
What percentage of patients actually have that level of expression?
It's around a third of patients. So this is a real group of patients who have a potential to have a relatively non-toxic and effective therapy, which can be associated with durable responses.
And a clear survival advantage.
Exactly.
So the notion that we can take a third of patients with advanced, incurable disease, whether it's metastatic at diagnosis or recurrent, and actually change their therapy, not change, but supplant our standard therapy is really a major game changer, I think.
I totally agree. And then the other thing is that it's just adding another tool to our armamentarium because chemo still works for these people.
So if they do develop disease progression on pembrolizumab, the same chemo is still available.
Exactly.
And what about in the second line setting? It's only been since March of 2015 that we had an indication for the use of immunotherapy in the second line after prior platinum exposure. What's your take on the current landscape there?
Well, we've gone from starvation to plenty there, really. We've gone from having really just docetaxel. It's now an immunotherapy in the second line. We have nivolumab, we have atezolizumab, which is a PD-L1 inhibitor, and we have pembrolizumab, which has an approval amongst patients who have some staining for PD-L1. Both atezolizumab and nivolumab have a PD-L1 agnostic indication. But I think that we now have multiple options of treatments that are effective. And of course, we don't have direct comparisons in an individual trial, but it seems that all these agents are active for these patients. They have slightly different safety profiles, slightly different dosing frequencies, and I think that it'll be interesting to see how practitioners utilize them.
But beyond that, they're far more alike than different. I mean, we've seen very similar response rates in the phase 3 trials, 15 to 20%. Which isn't very high, but certainly higher than the 8 to 10% we've seen with docetaxel. In the squamous cohorts, we do see measurable improvements in progression-free survival, and then across the board, a survival advantage compared to, again, standard second-line chemo. So where does that leave docetaxel or docetaxel and ramucirumab?
Well, I think that it really just moves it back a step in terms of the next line of treatment. If I have a patient who has received cytotoxic chemotherapy in the first line, my second line treatment is going to be immunotherapy at this point in the absence of a very good biomarker that would decide whether or not I should do that. But I think that, and then docetaxel goes beyond that, but I think that useful biomarker is a critical next step for what we need to derive from.
So you would be in favor of actually measuring PD-L1 status at diagnosis at this point?
At diagnosis for all patients based on the Keynote-24 data. But in the second line, the PD-L1 status is not terribly useful because our second line treatments, things like docetaxel, are not as effective as first line platinum doublet. And so selecting out that patient population, even the PD-L1 negative, have a response rate that's
So defeating docetaxel in second line, in a sense, was a much easier task than actually showing a benefit compared to a frontline platinum-based combination.
Exactly.
So the PD-L1 testing in your mind then should be reflex
Absolutely.
At diagnosis, along with TTF1 and P40, P63 to look at histology. Speaking of histology, we had some very interesting talks here by Shakun Malik from the NCI, and later on Friday from Vali Papadimitrikopoulou from MD Anderson. She's spearheading, of course, the S1400 trial. So what are your thoughts about squamous cell carcinoma? Let's assume the individual does not have high levels of PD-L1 expression. What would be your treatment paradigm in 2016? What would you start off with? What would you do second or third line?
So my first line generally for patients with metastatic squamous cell carcinoma is nanoparticle albumin-bound paclitaxel. And that's based upon the comparative study that was done by Mark Sosinski and others, where they looked at solvent-based paclitaxel or nanoparticle albumin-bound paclitaxel, and they found that the response rate was nearly double when you use nanoparticle albumin-bound paclitaxel, and that's also associated with an improved side effect profile. There's no infusion reactions, there's a lesser rate of neuropathy, and so that has been...
Infusions are faster and doesn't require steroids.
Yeah, so it's a nice option. So that's my first line, and then in the second line I use immunotherapy. Beyond that, it gets into a bit of messy waters, honestly.
So how would S1400, this sort of pan-US clinical trial, really address that? And if you can mention some of the particulars about that trial.
Absolutely. So that's a really exciting trial because in adenocarcinoma, we've been able to identify targeted therapies using pills that often replace our use of first-line systemic therapies, which were previously intravenous, and have much better response rates and all these things. And trying to reproduce that in squamous has been elusive. First of all, because it's hard to identify a target to get at, and then once you identify the target using a therapy for it, the effectiveness is not always there because you need to identify not only a mutation, but what we call a driver mutation, the thing that's making that tumor behave like a tumor. So what S1400 is trying to do is it's doing next generation sequencing through Foundation Medicine of all of these squamous cell lung cancers for second line and beyond, and identifying certain subgroups. So specifically, there's a PI3 kinase mutation subgroup, there's an FGFR mutation subgroup, and there are others. There's now going to be more in terms of mismatch repair and all these other topics. And identifying those patients and then giving them targeted therapies. It's a great idea. We'll have to see how it pans out.
I think there are a number of concerns whether these identified biomarkers are truly drivers or whether they're, you could call them fellow travelers perhaps. The other concern is that many of these overlap. They're not, they don't seem to be quite so distinct as we see in non-squamous, where those with EGFR mutations virtually never have KRAS or ALK translocations. And we don't really have well-identified agents yet that can necessarily target these molecular aberrations, but certainly this trial will help deduce that. What about, you mentioned your default option for second line and those without a marker is immunotherapy. How is this study addressing that group, the group that does not have a matched biomarker?
So currently there's an arm open that randomizes patients to either nivolumab or nivolumab plus ipilimumab, the CTLA-4 inhibitor. And that, I think, is a very important portion of the study because, first of all, most patients don't have a biomarker. And second of all, that question truly assessing PD-1 inhibition alone versus PD-1 inhibition in combination with CTLA-4 is a really important question because the incorporation of CTLA-4 inhibition has significant toxicity. And so prior to adding that in, we really should have a good sense of what benefit we're providing.
Of course,
for
the squamous cell population, individuals tend to be older. They tend to have more comorbidities. We're already talking second line treatment as opposed to front line. So obviously a lot of care needs to be performed and making sure that the safety norms are not violated here.
Yeah, and there's also now, there will be opening another arm for patients who have previously received a PD-1 inhibitor, and that will utilize a combination of CTLA-4 and PD-1, and the idea there is to identify whether the inclusion of a CTLA-4 inhibitor can overcome the resistance
Can actually
to
reverse
PD-1.
the resistance that's been observed.
And it'll be interesting whether that works in both patients who have primary refractory disease, so those patients who never responded to immunotherapy, or those patients who responded and then stopped responding. And those are going to be likely two different groups.
Yeah, my bet is it'll work better in the second group, but
exactly.
not so much the first. And I think this trial is very important and really sort of sets a stage for other similar trials, in that we're really rolling 5, 6, 7 trials all into one, under one basket, so to speak. And that if we tried to do these independently, we would overwhelm our own resources and overwhelm our IRBs. We could never really accomplish accrual to each of these sub-trials as an independent entity. You're presenting data at this meeting on small cell, and for the first time we actually have a potential targeted therapy, rovapatuzumab tesirine, an immunoconjugate. Can you tell us a little bit more about this agent?
Yeah, this is really exciting because for the last 20 years we've had really very little advance in small cell lung cancer, despite very impressive advances in non-small cell. Rovapatuzumab tesirine is an antibody-drug conjugate. So the antibody targets DLL3, the delta-like ligand 3, which is overexpressed on small cell lung cancer, neuroendocrine tumors, and it's not terribly expressed on normal tissues. That's a really nice target for the use of a antibody-drug conjugate. It's bound to a microtubule inhibitor, and like many other antibody-drug conjugates, the drug itself, if we were to just give it intravenously, would be far too toxic to use, but in terms of its cytotoxicity, it's quite effective. So the exciting thing about this drug is that we're seeing responses in second and third line treatment of small cell, which we previously were not seeing.
Really refractory patients.
Really refractory patients, because it's a different mechanism of the drug. It's similar to what we're seeing in immunotherapy, where we say, okay, if they're going to respond, it doesn't really matter how much they've had before. If they're going to respond, they're going to respond. And that's an exciting next step. It's a pretty well-tolerated drug. The major side effect outside of the common side effects we expect with chemotherapy, things like lowering of platelet counts, the interesting side effect which can exist with it is increasing effusions, which happens about 11% of the time at a significant
And this can be
degree.
both pleural effusions, ascites, peripheral edema, so it's sort of a pansericitis that's been observed. And apparently takes a bit of time to resolve. Steroids have been used. I think it's mostly tincture of time. It's also unique in that they're really just 2 doses, 6 weeks apart.
Yeah, and they give the 2 doses, and then you wait for a response, and then if they respond and then relapse, there's a thought you might be able to re-expose them. And I think that connects with the long half-life of antibody-based drugs, but it's distinct from other antibody-based drugs that we've used clinically.
Well, in truth, we don't really know the optimal duration of the PD-1 or PD-L1 inhibitors. We tend to give them just indefinitely in the absence of disease progression or toxicity, but there, certainly amongst responders, there are studies, or the intent to conduct studies looking at 6 months, a year, 2 years, as opposed to just indefinite use. Speaking of oncogenic drivers, there have been a cascade of data over the last, not necessarily the last year, but certainly the last 5 years. We've seen the approval now, as of 2016, for 3 separate oral TKIs, and those with EGFR mutations, erlotinib, gefitinib, and afatinib, and now osimertinib for those who have developed acquired resistance with T790 mutation. Tell me a little bit more about osimertinib. It was only approved in November of 2015, so it's a relatively recent addition to our therapeutic armamentarium.
Well, I think that osimertinib is a really exciting next step for targeted therapies, and the reason for that is that the most common resistance mutation, regardless of the first or second generation tyrosine kinase inhibitor that's used for EGFR mutant disease, is T790M. And T790M renders the tumor cells relatively resistant to erlotinib, gefitinib, and afatinib. Osimertinib is a specific inhibitor that is designed to inhibit a T790M mutant, EGFR mutant non-small cell lung cancer. So what we were able to see in the trials of this agent are response rates and progression-free survivals that mirror what we saw in the first line with EGFR mutant disease, seeing these fantastic responses in a relatively well-tolerated drug. And it gives hope to the idea that this disease may eventually follow a chronic disease model where you can give a pill, and then if that pill stops working, you give another pill, and we can give subsequent pills based upon what mutations develop. And that's really an exciting aspect of targeted therapies.
So basically deferring the time to initiate chemotherapy, which one might argue would be a very reasonable endpoint for some of these trials.
Yep.
You know, time to initiation of chemo. So in that vein, literally, what about liquid biopsies? There's been a tremendous movement really over the last year or two, particularly in those who've developed therapeutic resistance to frontline TKIs, to obtain specimens, basically plasma specimens, looking at circulating tumor-free DNA. This obviates a biopsy. It's obviously a lot faster, a lot safer, both theoretically and in reality. How is that going to inform our approach? And do you see a time, maybe not the initial biopsy, but where liquid biopsies will ultimately displace the need for tissue biopsies?
You know, it's interesting. Liquid biopsies are a great step forward for patients. Because of the heterogeneous resistance to EGFR inhibitors, a repeat biopsy or repeat genetic acquisition at the time of primary resistance to a TKI is essential to guide therapies. But, as you say, doing a biopsy, it's not fun. Nobody likes it. The patient doesn't like it. The physician ordering doesn't like it. There's risk for side effects. So these liquid biopsies are very helpful in terms of getting towards a good outcome. When the studies have compared, so Heather Wakely presented at ASCO last year, and Jeffrey Oxnard has published a paper comparing the relative sensitivities of the liquid biopsies as opposed to a tissue biopsy. And it turns out that the sensitivity of the liquid biopsy is pretty good. It's around 70 to 75%. But what really drives the response to therapy is still in the tissue. And so if you look at patients who have disparate results, if a patient has plasma negative disease but tissue positive, they're quite likely to respond to osimertinib.
So if the liquid biopsy is negative, you would not stop there and certainly still go to a tissue biopsy. But the specificity is quite good. So if you can identify the abnormality, say T790 in the liquid biopsy, you need not do the
exactly.
tissue
So
biopsy.
you can obviate the need for tissue biopsy if you find a positive result. But if you find a negative result, you really shouldn't stop there and you should go for a biopsy if possible.
I want to turn to other antibodies. We've really focused mostly on the checkpoint inhibitors, but we do have the addition of ramucirumab in the last 2 to 3 years to docetaxel based on phase 3 data, the REVEL trial that showed a response, PFS, and overall survival advantage. Maybe we've become a little bit jaded. It's not quite so impressive as the checkpoint blockade, but had we seen similar data 10 or 15 years ago, we would have been quite impressed. And then, of course, necitumumab, a monoclonal EGFR antibody that in combination with standard chemo, in this case a gem platinum platform, has led to improved overall survival compared to standard chemotherapy alone. Where do you see those agents fitting in, and how do you think we should further develop those agents, particularly in the context of immunotherapy?
Well, I think that both of those agents are, as you said, a rather victim of their timing. So, you know, they came out right as checkpoint inhibitors were coming out. We were seeing these fantastic responses with low toxicity. It was hard to get excited about those agents. In terms of ramucirumab, because of the checkpoint inhibitors and our access to clinical trials, my use of docetaxel has declined substantially. And so my use of an agent that adds on to docetaxel is also.
But you would consider it third line?
I would absolutely consider it if I had a patient who I was treating with docetaxel. Necitumumab is a little bit trickier because first of all, it was only a subgroup of patients who benefited from the necitumumab in terms of on a histologic basis. And in addition to that, in the first line, remember for nanoparticle albumin-bound paclitaxel, I use it for squamous, and for adenocarcinoma, I generally use a pemetrexed-based regimen. So I don't use a first-line platinum doublet that is on a gemcitabine backbone. I think that for both of these agents, really the path forward is identifying the subgroup of patients who benefit from their therapies. So looking at biomarkers to identify who is the patient population who will benefit.
And there's movement afoot to reinvigorate FISH as an identifier of EGFR amplification or other abnormalities that might make individuals more sensitive to the combination of necitumumab, at least with chemo.
Yeah.
The statistically significant but marginal improvement in survival seems to broaden quite a lot when we can identify subgroups that are more likely to benefit. I want to turn to another area that I think is very, very important, and that's the role of supportive care and palliative care in the management of our patients. Jennifer Tamel, about 5 years ago, came out with I consider a landmark paper published in the New England Journal looking at proactive versus reactive supportive care, population of advanced lung cancer patients who met with a team of additional providers, allied healthcare professionals, pain management, psychiatry, nutrition, etc., as they went on with their standard treatment. That team was not denied to the control group, but they did not meet formally. They sort of met on an ad hoc basis with individual advisors. And the endpoints of her study were really quality of life, anxiety, depression, utilization of healthcare services toward the end of life, whether individuals went on hospice, whether they required hospitalization, and ultimately survival. So if you can expand upon some of those data and how her study has informed our practice in particular.
I think that study, I totally agree, that's a landmark study. And what they were able to show was that the early incorporation of these supportive care measures prolonged overall survival for these patients.
Which wasn't a primary endpoint of the
No,
trial.
but it's hard to ignore the degree of improvement. And I think it speaks to the value of listening to our patients and responding to their concerns proactively, rather than this sort of old concept, oh, you gotta, no pain, no gain. Like that's just clearly wrong when you look at things like Dr. Temel's work. So focusing on patient symptoms early and managing them is critical. And I think that lends into incorporation of multiple healthcare providers. It can't just be one PalCare doc that we send him to. There are nutritionists that are involved, there's chaplains that are involved in terms of support, not only for the patient, but for their family. And it's important to make the distinction between palliative care, which refers to improvement of quality of life and focus of quality of life throughout their treatment, and hospice, which is really treatment currently at the end of life, where we're taking away any sort of therapeutic towards the cancer treatment and focused only on quality of life.
But there is a tendency, I think, amongst the general public and even amongst many of our colleagues to equate palliative care with hospice.
Yeah.
That study was remarkable in that it showed decreased anxiety, less depression, more hospice use toward the end of life, fewer hospitalizations, fewer hospital days. So essentially every endpoint was positive. Granted, it was a small study, and I'm not aware of any study that's actually duplicated that.
They've worked to duplicate it, I believe, but one of the issues is that the team that they have up in Boston who's doing that is an excellent team, and it just supports the concept that incorporation of teams like that is useful.
So, and it really validates the notion that supportive care, when implemented properly, can not just enhance quality of life, but can actually enhance outcomes in terms of survival. So, as many people have said, it sort of takes a village to really help our individual cancer patients out, that no single individual can provide a remedy.
Yeah, I completely agree.
So this has been a pleasure, Josh.
Thank you.
Again, I deeply appreciate your insights as time goes on in the management of advanced thoracic malignancy. We've witnessed a tsunami of new trials, many positive in the past 2, 3, 4 years, that have really informed our therapeutic decision making, and it's made treating this disease a lot more rewarding, a lot less futile, a lot less demoralizing, and I look forward to advances to come. So again, Corey Langer, Director of Thoracic Oncology at the University of Pennsylvania at the Abramson Cancer Center, with Josh Baumel, an Assistant Professor at Penn. We thank you for your attention and participation.